So part two was extended for longer than I had anticipated, but what I've decided to do is to separate the second session into effectively a third part. And so what we'll be doing now is to discuss um, the second parts that we need to discuss from an ethics point of view, and that the first is non-COVID patients, and what happens to them in the health system during a pandemic. And the second part is, looking into the future with regards to the vaccine development and implementation. So the question around non-COVID patients is really focusing on the patients who would, in normal circumstances, need to access health services, and this could be acute issues as well as chronic issues. And for the purpose of this part, I'll focus on chronic issues because those are usually patients who have to continuously use the health system. So, what happens when a patient who is not infected with COVID-19 presents to the hospital setting requiring a bed or a ventilator? So, this could be, for example, a patient who has another type of respiratory condition that is not necessarily COVID-19. And so, what you see on the one hand is a COVID-19 patient who's either moderate or severe in need of a ventilator versus a non COVID patient who needs the exact same resource, such as a bed or a ventilator. And what happens to that specific situation. So in the resource allocation discussion thus far, we focused mainly on COVID versus COVID patients. So now we're looking at COVID-19 versus non-COVID-19 patients. And it is important to assert that it is not ethically justifiable for COVID-19 patients to be prioritized over other patients outside of the rationing guideline. And so, what I mean by that is that what is applicable in the COVID situation must be applicable in the rationing process in general. And this means that if you have a resource such as a ventilator and you want to ration it according to the need, and this is also considering non COVID patients, you will have to apply the exact same principles. So the principle of utility is still applicable when you juxtapose a COVID-19 patient against a patient who's not a COVID-19 patient. And so what that means is that if the non COVID 19 patient has a better prognosis or stands a chance to effectively benefit more from a ventilator than a COVID 19 patient, the non COVID 19 patient should receive the resource, right? So if effectively a patient who has a specific respiratory disorder needs a ventilator and they stand a better chance at gaining the utility, and they have a better chance at surviving, or their case is in fact more severe than the COVID 19 patients that are available, they should be allocated the resource. So it is important to understand that the rationing process should not be limited to the pandemic itself, but it should be applicable to all of the patients who would need services in the hospital, because it's about resource allocation in a way that's equitable. And this means that it must consider all of the cases equally. So, what this means is that other essential services should not cease or be limited because of COVID-19 prioritization. And this has made a lot of or at least been a cause for a lot of debate in society, because when there is a focus on one epidemic or one outbreak or one pandemic, there's an over centralization of research funds, of resources such as protective equipment, and even of the functioning of certain departments and wards towards that particular pandemic. And so what happens then is, at the expense of other essential services, there is a prioritization of, for example, an outbreak or something like COVID-19, which is an epidemic. And so, as I say, the rationing guideline is not exclusive to COVID-19 cases. It is to be applicable, and the principles that are applied, such as utility and those that are worse off, high risk, random lottery, as well as distributive justice, these should be prioritized to all people who present in hospital and are in need of health services. And it is also important to note that there is a cost to over centralizing certain resources and funding towards one health priority over others, right? So, for example, a study has done projections, and they found that if there's a 6-month disruption of ARV treatment or ARTs, this could result to up to 500,000 deaths, a doubling of mother to child transmissions of HIV over a year in sub-Saharan Africa, and an increased mortality rate of 40% in the next 5 years. Now, this is absolutely important to consider given the amount of resource prioritization that has gone into HIV and other diseases such as TB. And so, what you don't want to happen is in the rationing process to ignore other important um, health issues to the extent that you undo some of the work that has taken years to achieve because of a over prioritization to one pandemic or epidemic in a country. It is also important to note that limiting medications or access to medications for other chronic illnesses will obviously result in the worsening of those diseases and can increase the mortality rates to those that have been suggested for the HIV. And there's another consideration that is absolutely important in that when you seize or disrupt certain types of treatments, they have a high propensity to effectively be resistant. So we know that TB medication requires very strict compliance because of the risk of resistance. And so if you disrupt TB medication distribution and access, there is a high risk. And cumulatively, you could find that by over centralizing resources to COVID 19 services may result in more deaths because of the under centralization or under prioritization rather of other disorders and diseases. This picture is a screenshot of a newspaper clipping, or at least an alert from UCT, and it's basically an article that describes some of the ways in which the COVID-19 response is hurting other health priorities. And so this is an issue that I think at the moment is probably being discussed, but not with the understanding of the effects of disrupting other health services and what that would mean in the future. And so when you consider, for example, mortality rates, whether you are classifying them per disease, the COVID-19 response, if it is to affect other health priorities, will result in um, more rates of mortality in the health setting of South Africa. The next point of discussion is of course, a vaccine. So we know that COVID-19 does not have a cure and it does not have a vaccine. And so the vaccine has been identified as a easier, quicker way to manage COVID-19 as a pandemic. And the point is to develop herd immunity and in such that a certain percentage of the community is vaccinated and has antibodies in their system that will prevent people from developing an infection or at least being infected, as well as limiting the risks associated with infection. So, vaccines have been topical in the COVID-19 discussion. And as of the 31st of July, the World Health Organization reported that these are the number of clinical trials that are in the phase 3 of the vaccine development. So, there are other clinical trials that are currently working on a vaccine for COVID-19, which include Wits University. These ones are the major contenders because they are in phase 3. So phase 3 effectively means that they've obviously done pre um, clinical trial, phase 1, phase 2, and this is phase 3, and they're implementing the vaccine in bigger and broader populations to test for efficacy and safety, of course. And so while we have clinical groups or clinical trial groups that are working on these vaccines, another conversation that is, of course, brewing is how then will we distribute the vaccine once it is here? It is important to note that, of course, Vitis is working on a vaccine as well. However, the ones that are making fast progress are not any of the African countries are not represented in these clinical trial groups, at least to my understanding. Sinovac is not. Wuhan is in China, Beijing is in China as well. Moderna and Pfizer is the United States, and Oxford is in the UK. So, how should the vaccine be distributed? There are four principles that we'll just look into in terms of a way, one of the ways, a guide that can inform how vaccines are distributed. The first is ability to develop and purchase the vaccine. So, on the one hand, which countries, which research groups are in fact able to develop this vaccine. And then the second is who can actually purchase the vaccine. And it is important to note when you talk about development and purchasing, there's a lot of disparities amongst countries when you talk about the global perspective of resource allocation. So some countries, like the United States, have purchased or plan to purchase exclusive access to COVID-19 vaccines. And so it is important to interrogate whether this is in fact ethically justifiable. I would argue that it is on its own not ethically justifiable to reduce the distribution process and guideline to access based on ability to develop and ability to purchase. And then the next principle is the principle of reciprocity. Reciprocity has proven to be important in previous cases of vaccine development and is in fact just as important now. And so what happens is that there are countries, multiple countries that are involved in the development of the vaccine. So they assist in the actual development of the vaccine, but also participate, for example, in research trials. So it could be that there's a first world country that is the one that has the capacity to develop the vaccine. However, when they do their clinical trials for the vaccine, they test it in other countries. And so when we talk about reciprocity, we acknowledge all players in the vaccine development process, which includes those who have the capacity to develop and purchase, but also those who participate. And so what this principle asserts is that it's not correct and it's unethical to have a system where the country that has the capacity to develop exclusively has access to the vaccine to the exclusion of countries that participate in the development of the vaccine through being participants. And then ability to implement is very important, and this considers utility. How will this vaccine effectively be implemented or distributed in hospital and clinical settings at individual country levels and also at global levels. And so some of the things that must be considered, is which groups are likely to survive. And this is not to think of a group as race or a country, but within the countries, who would be prioritized. So one example which was discussed in the previous part was those who are high risk. So it could be that the people who stand to gain the most and the people that should be prioritized the most would be people who are high risk, would be people who have been detected as those who are most vulnerable to this vaccine. And so when we say globally, who do we implement the vaccine to first, it would be considering a broad category of populations and looking specifically at utility and looking at the risk and mitigating the risks specifically for higher risk and vulnerable groups. And then finally, distributive justice, of course, is not something that we refer to at a country level. There are different stratas in which countries operate and exist at an international diplomacy and at least political landscape. So when we talk about a vaccine, it needs to be shared and distributed equitably, and all countries, including countries that are developing, should have a fair opportunity to access the vaccine. And this is also important to consider the need. So distributive justice definitely considers fair opportunity and need. And what would be most equitable would be to consider the high risk communities first and to ensure that they are given preferential treatment or first access at least, and then obviously then fair opportunity generally to communities, which include developing countries, would be very important in the implementation of the vaccine. So, we have discussed a lot, and please feel free to contact me if you would like to chat a bit more about some of the aspects of this lecture and some of the questions that were raised and some of the ethical analyses and principles that were applied. So, in this lecture, we obviously covered the background information of COVID-19, which I'm sure all of you knew what that was about. Then we looked at, how resources ought to be allocated ideally, right? So, the factors, such as clinical factors or physical and signs and symptoms. Very simple, no complicated approach to allocation of resources. And then we complicated and confounded the situation by looking at contextual factors such as challenges and resource limitations, and how then we need to kind of redirect our resource allocation lens to a more principled view, and to ensure that there's equitable resource allocation in resource constrained and limited environments. We looked at the ethics, right? The ethics that motivates these rationing processes for constrained health systems. And we not only looked at that for COVID-19, but we also had an assessment at other essential services, for example, the example of HIV, TB, and other chronic illnesses. And then finally, we looked at some of the principles that should inform the vaccine distribution once the vaccine has been approved. Thank you for making it this far, and I hope you enjoyed the lecture. And again, please feel free to contact me should you have any questions. Thank you.